So I'll start with a short history about radiology services in Tanzania. So for the first time, the recorded time that radiology service was started in Tanzania, it was during the colonial time. There was no documentation about radiology services during the pre-colonial time. So most of the recordings during the World War I were a number of X-ray machines were introduced in the country. But after that, after independence, and then we had our own institute for training radiographers, that is radiographic auxiliaries. These were primary school leavers who were trained just to do X-rays, just to do chest X-rays and long bone X-rays. And after that, from 1964 to 1971, where the institute was upgraded, and they started giving a diploma in radiography, and the former school for radiography auxiliary was shifted to KSMC and then to Bugando Medical Center. So all this time, the only thing that we were using to do it was just X-rays and fluoroscopy studies. And in mid-90s, that is when we started with ultrasound services in Tanzania. And for radiologists, the first program was started at KSMC in 1998, where they were offering 4 years course in radiology. Then at MOAS from 2007, where they were offered 3 years course in radiology. Currently, we have more than 100 radiologists, and we have super specialist radiologists. Some are doing women imaging, some are doing interventional radiology, and a number of them doing neuroradiology. So as I've said, from just after independence to 70s to early 90s, the main radiological services that was available was X-ray and fluoroscopic machines. But in late 90s, that is when we started having ultrasound services available. Mainly it was at MNH. So the first CT scan were introduced in Tanzania by the Ministry of Health in 1996. Where 2 machines that were 16 slices CT scan machines were introduced at MNH and at KCMC. MRI services were started in mid-2000s, and PET CT scan will be started this year at Ocean Road Cancer Institute. So currently we have a number of modalities that we can choose from. We have X-rays, which have a lot of them. We have ultrasound machines, we have a lot of CT scans. As for now, the government is installing CT scans in all regional hospitals. So countrywide, we have more than 50 CT scans which are available in Tanzania. That is a good thing, but it's also can pose it as a challenge on choosing wisely. Just because they are available, then we should know when to use them. Then we have a number of MRI machines. Currently in Dar es Salaam, we have more than 10 MRI machines. And as I've said, we are hoping that this year we are going to start our PET CT scan services at Ocean Road Cancer Institute. So on choosing wisely, one is to be sure what he's dealing with and what he or she wants to achieve. The first thing that you should know what kind of malignancy that you are dealing with, both the type and the location. If you know the anatomy or you know the diagnosis exactly, then you can know what investigation that you want to do. For instance, if you have a patient with, let's say, head and neck tumor. So with head and neck tumor, then you have to know which investigation am I going to do. Should I do a CT scan or should I do an MRI? Will just ultrasound be enough if it's a thyroid tumor? Or should I do both, from CT scan, ultrasound, and MRI? So even if it's a head and neck tumor, then you have to know, is it supraioid or infraioid? If it's supraioid, what should I do? An MRI or CT scan, and why? So that will give you a clear picture as what do I want to do. Now, if it's a supraioid tumor, then you say I'm going to do MRI or CT scan. Then you have to ask yourself why. What do you want to achieve? Are you just doing an explorative imaging to see what is happening, or you are sure that the tumor is there, so you want to see how it is going to other structures? Then if you ask yourself what you want to achieve and you know your anatomy and your pathology, then it becomes easier for you as a doctor, but also for the patient. So those are the things that you need to ask yourself before you order an investigation. It's not just a matter of clicking on the system, just I want this and this and this and this. It has to be a reason, and you have to know what you're doing. Also, you have to know the stage of the diseases, because as for example, if you are dealing with CA cervix, the higher stages, then you can do a simple investigation. You can go up to a CT scan, but if you have a very high area stages, then maybe you'll do an MRI for that. Then the size of the lesion will give you an indication what kind of investigation you do. If it's a very small tumor, then you can just say, okay, maybe it's a neck lesion. You can say, maybe I'm going to do just an ultrasound. But if it's a huge tumor, then you can go for a CT scan, because you want to see the extent of the tumor in the neck and also on the upper part of the chest. And also, as I've said, you have to know why are you doing the imaging. Is it for staging, or is it for just looking for the extent of the disease? Are you looking for the treatment response? All this will tell you what type of investigation we are going to do. But also for the patient, also you are the doctor, you have to be aware of the availability and the affordability of the test, because some tests are good for a given condition, but they can be expensive, and maybe the patient will not be able to afford them. So as I said, imaging is important for staging, treatment response evaluation, for radiotherapy planning, and currently most of the conventional imaging that we are using, they have limited use, but that will depend on the stage and what you want to see. But most of the time, when you have a patient with cancer, then the cross-sectional imaging is what to do. So as we have said, and most of the speakers have said, cancer of the cervix is the most prevalent cancer here at our setting, which constitutes about more than 40% of cancer patients cancer of the cervix. So I'll just discuss about cancer of the cervix as just a prototype to see how we can go about to see what kind of investigation that we should order. But that also will depend on the stage of the patient. But as we have said, most of the patients, they come at late stages. So my talk will be more on stage 2B going forward, and I will spare the stage 1A and 1B and 2A. So most of the time we usually do chest X-ray. Chest X-ray are good, but they are not that much good. We can just go ahead and do CT chest, which is more superior to chest X-ray. We can use chest X-ray if you just want to see if there is pleural effusion or if there is overt pulmonary metastasis. For ultrasound, as we normally use it, it is good for assessing the tumor, yes, but it will not give you the extent of the tumor, specifically the parametrial involvement and involvement of the pelvic walls. But also, it can tell you about hydronephrosis, which is very important while you are doing staging. But it is not as good as what we can achieve with CT scan. Point to remember that ultrasound is user dependent. So if you have a CT scan at hand, then it will be better if you go for CT scan rather than just going for ultrasound. As I've said earlier, conventional imaging have limited use when you are dealing with a patient with cancer, unless it's something which is very obvious. CT scan currently is what we use in most of the time, because it has a very good accuracy compared to the X-ray and ultrasound, with the accuracy of 32 to 80%. The range is quite wide, but it depends on the stage. If you have a very small tumor, early stages, then it is difficult to see with CT scan. But the accuracy of CT scan is increasing as the stage is increasing. With a bigger tumor, then it is easier to see with CT scan compared to with ultrasound. And also on evaluation of parametrial involvement, it is sensitive with average sensitivity of 64 and the specificity of 81. But all it depends on the stage of the tumor. And when it comes to lymph node assessment, which is a very important part when you are doing CT scan for staging, it is sensitive about 31 to 65%, as I've said, depending on the size and stage of the tumor. It is quite, I can say good, positive predictive value 51 to 65 and negative predictive value of 86 and 90 to 96%. The only setback here that we know on CT scan, we use size criteria. We just look at the size. If it is more than 1 centimeter, then we say this is most likely metastasis. But if it is less than that, then we say maybe it is benign. But with that, then you can miss some of the tumor, because some tumors are small, but they are metastatic. Also, it is good for evaluating distant metastasis, especially for the chest or pulmonary metastasis. MRI is accurate, especially when it comes to determining the size and location of the tumor. If you want to know the tumor, if it is exo or endocervical, then you can use MRI. With studies showing that the actual size of the tumor and the MRI size prediction, the only difference is about 5 millimeter. If you compare the surgical sample size and what the MRI will tell you, the difference will be somewhere between 5 millimeter. It's good in staging with the accuracy of 75 to 96%. That is more than CT scan. But also it is simple and used to tell if now I'm dealing with either recurrence or it's just a normal cervical tissue post-treatment. You can just use, basically we can use T2 weighted images where tumor cells will appear hyperintense, or we can just do diffusion weighted images which will also appear hyperintense. But also in ADC they will have low values that will be able to tell you if this is a recurrent tumor or just remnant tumor or a treatment response. The same will apply for lymph nodes. If you do a diffusion weighted image and ADC, if you see low ADC value, then you know this is most likely I'm dealing with a metastatic lymph node. Now when you come to PET-CT scan, it is good also for smaller tumors, but the different studies have different opinion about the superiority of PET-CT scan compared to MRI when it comes to node evaluation. Some studies say they are of same accuracy. Some say MRI is lower, and some studies say PET is lower. So it depends, I guess, on the stage, because all three modalities, CT scan, MRI, and PET-CT scan, the main pitfall is the size. All of them, they operate poorly when you have a size of less than 5 millimeter to tell if it's a metastasis or not. So as you've seen that I've mentioned a lot of numbers, they can be somehow confusing. Now what should I do with all those sensitivity and specificity? Or it comes to the stage and what you want to see. So for most of our patients, they are stage 2B and more than that. So this is the appropriateness criteria by ACLL, that American College of Radiology. This is what they've done a lot of studies, and this is their recommendation for advanced CA cervix. You can do an MRI pelvis, that is if it is available and it's affordable, with contrast. It will give you an advantage to see the tumor itself, the inversion of the parametrium, lymph node inversion, and even distance metastasis. The rating is 9, and I'm saying 9 because if it is 7 up to 10, that we say it's appropriate. If it's 6 to 4, then we see not appropriate. Yes, below 6 is not appropriate. The 2s are, you better don't do it. So MRI is more superior compared to CT scan, because it will give you exactly tumor size, it will give you node involvement, it will give you if it's recurrence or post-treatment lesion. It will be able to tell by just using T2, ADC, and diffusion weighted sequences. You can also do PET-CT scan with the rating of 9. The main advantage with MRI is radiation free, but with PET-CT, then you expose the patient to radiation between 10 to 30 millisieverts. It depends on the protocol. The dose will depend on the protocol.
So the relative radiation level will depend on the protocol that you are using. But MRI has no radiation. So you can also use a PET-CT depending on the variability and the affordability. You can also use CT scan, as most of us are doing, but rating is 7 compared to MRI pelvis, which is a rating of 9. It will give you quite a fair status of the tumor. But for smaller tumor, it's not doing very well, and it has limitation when it comes to lymph node assessment, as we are also using the criteria of 1 centimeter or above. While in MRI, you use the size criteria, but we can also employ the advantage of diffusion weighted images in ADC map. We can also use CT scan chest, that is for assessment of distance metastasis. It has to be contrasted CT scan chest, because if you do a non-contrasted, if you have a nodule, it can be anything. Maybe you have a past infection. I cannot tell you. But if you do a contrasted, then I'll look at the pattern of interest, enhancement. If it's homogeneous, then I think maybe this is a benign region. But if it is heterogeneous, then I'll think of metastatic regions. Chest X-ray, it's not appropriate to do it, especially when you have a stage 2B and above, because most likely you are doing, we are dealing with metastasis. But if you do a chest X-ray, most likely I'll tell you it's a normal or it's a pneumonic changes. But if you do a CT chest, then I'll be more specific, and I'll be able to tell you if this year we are dealing with a metastasis or not. For most of our patients that we see advanced stage 2B to 4, CT scan chest contrasted will be more appropriate compared to chest X-ray alone. Also the pelvis ultrasound, if the size of the tumor is big, then it's okay, we can see it, but we'll not be able to tell you if there's involvement of the parametrium or adjacent structures. So if you can go straight to do an MRI pelvis, if it is available and if it is affordable, then that will be much better. But the good thing is also that it has no radiation, so you can use it, but for staging, it's not giving you what you want. I'll just tell you it's stage 2B, but once you do an MRI, then I'll tell you stage 4A. But all in all, what to choose, what kind of image to choose, it depends on the diagnosis, location of the tumor, and exactly what you want to achieve. So that is what I had to say. I chose CA cervix because it's more common, it's more prevalent compared to other kind of tumors here in our setting. And I think if we start with that one, then we can slowly start to change and go to other kind of tumors on what we can choose and what we can do. If someone has questions, then you can just ask from the radiology department, I have this kind of tumor, what should I do? Instead of ordering a lot of investigations, they're expensive, and most of them, they don't pay, then it's expensive also to the institute, then it becomes a little bit cumbersome. So I think that is all that I have to say. We can just conclude with this slide. I had the last slide just to say thank you, but I think I can conclude here.